Hello everyone, welcome back to Cology Code. Today we are going to discuss Clostridium difficile associated diarrhea. Diarrhea is defined as watery stools scaling between levels 5 to 7 at the Bristol stool chart without bloating and predominant abdominal pain. In this video, we are going to discuss about the diarrhea a patient experiences due to infection by C. difficile. The causes of diarrhea are many, but for C. difficile infection, in many cases, is antibiotics like ampicillin, amoxicillin, cephalosporins, clindamycin. There are 4 ways to diagnose C. difficile associated diarrhea, which are as follows. First is bacterial cultures, which is a slow procedure. The presence of pseudomembranous colitis upon endoscopy. Third is the enzyme immunotherapy assay for the detection of C. difficile toxins A and B in the stool. It is a very sensitive test. And the next is molecular testing, PCR for toxin B, which is highly sensitive, but it is also very expensive test. Prevention is indeed better than cure. Good hand hygiene is always recommended. But in case of inpatient CDAD, avoid direct contact, use protective gear while in the same room as the patient, maintain patient isolation, and ensure the medical equipments are well sterilized. In the treatment of diarrhea, the first priority is to re-establish electrolyte imbalance. The offending or causative antibiotic should be discontinued. In cases of confirmed CDI, eradication of the infection is standard plan of action. The pharmacological choices vary based on the severity and recurrence of the infection. In most non-severe cases, metronidazole is considered rather than vancomycin or fidaxomicin. For severe CDI, the regimen includes either vancomycin or fidaxomicin. In fulminant CD colitis, FCDC, there is acute inflammation of colon and systemic toxicity. For this, the treatment is either vancomycin 500 mg oral 4 times daily or metronidazole 500 mg IV every 8 hours, and if there is ileus, then the patient will also receive vancomycin 500 mg in 100 ml saline every 6 hours through the rectum as retention enema. The treatment for first, second, and third recurrence are mentioned here. There is a standard vancomycin regimen or a tapered and pulsed regimen, and there is also something known as fecal microbiota transplantation, also known as FMT. Let us learn a little more about this. What is vancomycin tapered and pulsed regimen? Vancomycin tapering is done by reducing the dosing frequency over a few days and then the vancomycin high dose is pulsed every 2 to 3 days for 2 to 8 weeks. So this tapering and pulsing is known as the vancomycin tapered and pulsed regimen used in cases of recurrences. Let us understand FMT or fecal microbiota transplantation. It is the transfer of donor stool from a healthy individual to a sick patient either by colonoscopy or oral capsule delivery. It has been shown to restore initial dysbiosis. It has a success rate of 90% after single treatment. The major setback or risk of FMT is severe E. coli infections. However, this risk can be reduced or eradicated by proper screening and selection of the stool donor. CDAD in pregnancy and breastfeeding. Psyllium is the drug of choice for diarrhea in pregnant women, and for the infection Metronidazole can be used with some caution. In case of breastfeeding women, breastfeeding should be suspended while the patient is on metronidazole. Loperamide is an alternative for the diarrhea. That is all for this video. Please like, share, and subscribe. See you in the next one.